For my presentation, we'll be talking about pediatric septic shock. Septic shock is a severe inflammatory response in the body that can cause tissue damage and organ failure. There's a sepsis continuum ranging from early onset sepsis, severe sepsis, and septic shock. Sometimes incorrectly labeled blood poisoning, sepsis is the body's often deadly response to infection. Sepsis kills and disables millions every year. Like strokes and heart attacks, sepsis is a medical emergency that requires rapid diagnosis and treatment. The biggest difference between adult and pediatric sepsis is recognition. Sepsis is the leading cause of death in the pediatric population. In the U.S., more than 75,000 children develop severe sepsis each year. This works out to be about 200 per day, and the numbers are increasing by 8% every year. Almost 7,000 of the children die, and that's more than the pediatric population that dies from cancers. Mortality rates can range from 9% to 35% and rise drastically with each passing hour that sepsis goes unidentified. Many children who do survive sepsis are left with long-term problems. More than 34%, or 1 in 3 children who survive, experience a change in cognitive skills at 28 days following their discharge from the hospital. Nearly half return to the hospital at least once a year after surviving a diagnosis of sepsis. There are a multitude of risk factors that come along with septic shock, and those range from unsanitary conditions during birth, infections such as group B strep during pregnancy, a rupture of membranes more than 24 hours before birth, premature birth, chronic lung disease, congenital cardiac abnormalities, primary immunodeficiency, hemoglobin SS, which is the most common type of sickle cell disease, and infections such as pneumonia, influenza, meningitis, ear infections, urinary tract infections, open wounds, burns, or other injuries. Already hospitalized patients and invasive devices such as indwelling catheters can also start sepsis. The most common infections associated with sepsis are RSV, cytomegalovirus, E. coli, Candida, herpes simplex virus, and Listeria monocytogenes. In unvaccinated children, the most common infections are associated with sepsis include rubella, varicella, and HIV. Preterm birth African American infants are twice as likely to develop sepsis versus Caucasian babies. Sepsis is already a very difficult disease process to diagnose, but it is a secondary medical condition that develops after an initial infection, and its symptoms often mimic those of the original illness. Signs of sepsis include but are not limited to high fever, general illness or previous injury, shortness of breath, lethargy or being sleepier than normal, general pain or discomfort, nausea, vomiting, and dizziness. With septic shock, it's defined as a subset with cardiovascular dysfunction. Within the subset of septic shock, you have to have one of the following between hypotension or reliance on a vasoactive drug to maintain normal blood pressure, and you have to, in conjunction with one of the before listed, you have to have 2 or more of the following that are signs of inadequate tissue perfusion, and those include prolonged capillary refill time, oliguria, metabolic acidosis, and elevated blood lactate. A petechial or purpuric rash is also a late indicator of septic shock. I stated the signs and symptoms in the previous slide, but here's another slide that depicts a visualization of some of the common signs of sepsis. There's no one single diagnostic test out there for sepsis in existence. So to diagnose sepsis, a nurse or doctor has to get blood and urine samples. That would be followed by a very thorough head-to-toe assessment and monitoring for any changes in vital signs or mentation, even if they're very slight changes. You're going to check the blood and urine samples for elevated or low white blood cells, high levels of lactic acid, elevated C-reactive protein, and looking for any growth on cultures that are taken. Once sepsis is actually identified, the patient needs to be transferred to ICU as soon as possible. They'll be closely monitored and may require specialized equipment such as ventilators, stabilizing vital signs, the doctors will treat the sepsis with probably IV fluids, antibiotics, and other medications as needed. So using the American Heart Association's Pediatric Advanced Life Support Sepsis Shock algorithm and other hospital-dependent bundles and guidelines, that's the best way to treat sepsis. The nurse and all caregivers need to provide care per the physician's order, and routine care includes typically beginning oxygen via a non-rebreather face mask at 15 liters a minute, and that's regardless of the patient's O2 saturation. Some patients may require high-flow nasal cannulas or other things like CPAPs. Placing the patient on a cardiac monitor with continuous pulse oximetry is next, and you want to obtain 2 large bore IV lines with the largest gauge possible. If you cannot obtain IV access, you can try for IO access. There's a primary, they use rapid resuscitation fluids, so typically isotonic crystalloids, lactated ringers or normal saline, and that's typically given at a rate of 20 milliliters per kilogram. On top of giving fluid resuscitation, you have to strictly monitor fluid I and O and document it, so you're going to likely need to put in an indwelling catheter to monitor this closely. Then administration of glucose according to doctor's orders if there is a need to correct hypoglycemia, and calcium chloride or calcium gluconate to correct hypocalcemia if either of those are present. You would treat with antipyretics for febrile patients. And as I stated before, in diagnostics, you draw samples for a complete blood count with differentials. You're going to get an ABG, blood culture, serum glucose, ionized calcium, and serum lactate. You want to notify the practitioner of any critical laboratory values, and you always need to obtain the blood culture before antibiotic therapy. But there's a very strict timeline where broad-spectrum antibiotics must be given within 1 hour of sepsis recognition. And if you cannot get that blood sample within that hour, you go ahead and start on the antibiotics, because that's more important. You're going to continue to monitor the patient's vital signs frequently and check for signs of fluid overload every 5 to 15 minutes. From the Surviving Sepsis campaign, this is the algorithm for the initial resuscitation of children with sepsis. Some things we can do as nurses in the pediatric care unit is to immediately notify the healthcare provider if sepsis is suspected in a patient. Unfortunately, there is no screening tool for pediatric sepsis yet. You're going to want to maintain a patent airway, administer oxygen as needed, as well as fluid therapy, blood and urine samples, medication, and other things that are ordered per the provider. You want to make sure you're on the lookout and recognizing any subtle changes in mentation or vital signs whatsoever. And then we're going to, as nurses, want to educate the family on what to expect, possible causes of sepsis, and how they can prevent sepsis in the future. And then we can also educate pregnant women of common causes and preventative measures, such as vaccines that they can take to prevent sepsis in their newborns. This mnemonic is from the Sepsis Alliance, and the acronym is TIME. T is for temperature. You're going to notice a higher or lower than normal temperature in sepsis. You're going to be looking for infection, because sepsis often mimics signs of very common illnesses and infections. Any type of mentation change, so any mental decline, confusion, sleepiness, difficulty arousing, and then extremely ill was the E, so severe pain, discomfort, or shortness of breath. For health promotion, maintenance, and prevention, the key to preventing sepsis is to prevent an infection from occurring in the first place. Treat infections as quickly and effectively as possible. Prenatal care, including sanitary practices and proper testing and immunization schedules, is going to be the number one thing you do before a baby is even born. And then once they get to that 2-month mark, neonate 2-month mark, and into their childhood, regular childhood vaccines are going to help prevent illnesses. Proper hand washing reduces the risk of getting an infection, and just simple things such as proper care of wounds is going to reduce infection. So just cleaning with mild soap and water could mitigate the risk of sepsis. As far as health promotion, we know that there's primary, secondary, and tertiary prevention. And if you look at this chart, it kind of gives you an idea of exactly what you can do at every level of intervention. Here's another really nice slide that's titled How to Prevent Sepsis, but it also goes over what sepsis is, who's affected, statistics, common prevention practices, and the evolution of infection. We often view pediatric care through the lens of adult care, even when specialty care is crucial. Many state health departments, hospital associations, and policymakers have banded together to create legislation, regulations, and initiatives with common goals to implement evidence-based policies and processes and to educate staff to rapidly recognize and treat sepsis, collect data, identify gaps, and share sepsis prevention and best practices. The Surviving Sepsis campaign encourages hospitals to initiate sepsis intervention bundles. Hospitals can customize these bundles to maximize benefits as long as they uphold the same standards. There is the Sepsis Alliance hosts the Pediatric Sepsis Week, the third week of April every year, to raise awareness of the signs and symptoms of sepsis in children, and it also recognizes the survivors and to honor those who have passed. To find more information out about anything regarding sepsis, you can go to sepsis.org, as well as read, watch videos, and share stories in their Faces of Sepsis link. Thank you.